So just what Diet said, actually, and more male and female. What happens is, it is self-limiting. What happens is usually unilateral. The one femoral head starts to lose vascularity in it. Okay, so it starts to break down. It's what they call an aseptic necrosis. Aseptic meaning it's not an infectious process. It just starts to happen on its own. But they do feel that it's around a time where something triggers an immune response. So they feel like there was an agent, whether you realize it or not. Maybe they had a slight cold, maybe they had a slight viral infection, parasitic, something. But usually it triggers an immune response. And this immune response actually localizes to the hip and causes, what they say, this aseptic necrosis, basically meaning a breakdown, like the vascularity starts to lose, the hip starts to lose its vascularity, therefore they start to become necrotic tissue, breaks down, and then they can actually go into having, they usually pain, all the things that Diet was saying, problems with gait, limping.
The contrary, they never have pain.
Some do not, but classically,
I've seen 7 cases.
Mhm.
Because it's like every child, male child from the girls,
Yes.
from all sisters, every one of them had
had
it.
that.
And because there was no pain, right?
That's why they didn't.
They were thinking, oh, this is something wrong. This has got to be some voodoo. Nobody was thinking science.
Right.
Because the child wasn't complaining. All this child is falling. This child is limping. Oh, he stopped walking. And the progression, you don't want to hear the rest of it. It's parallel.
But eventually they do get pain because what happens is the hip will break. You know, they actually do, like, over time. And it is self-limiting, so they go through the phases. And again, classically, you know, because people, like, and like I said, I always think female because I've seen some female cases with it. But classically, you know, we always want to think, so it's male, can be a genetic component, but may not be. Autoimmune, attack of the cells, you know, again, vascularity in the hip, the femoral head of the hip. The breakdown can cause a fracture, can be very painful. And again, there's no history of injury or trauma, insidious onset, reduced range of motion, like you were talking about, intermittent appearance sometimes, a shorter stature over time, and muscle atrophy can occur. So, again, it's a disturbance of blood supply, avascular necrosis, synovitis, stiffness, pain, again, as the necrosis, you know, progresses. And again, you know, you could find patients that don't, but overall, you want to think of the classic, you know, in terms of what they're going to test you on. Collapse of the femoral head, bone fragments are eventually reabsorbed, and new bone growth will occur. So if you left the person and all this completely happened, eventually they would have new bone growth that occurs. Their immune response would be suppressed, and they would start to make some new bone again. But the problem is they already have deformity of the limb that occurs. That limb is usually shorter than the other, so that's where you get into issues overall. And then they do have a risk of dysplasia of the hip or a dislocation of the hip for the rest of their lives. Like some of the patients I had could not be put in like a lithotomy position ever because they would have a dislocation of the hip occur. And this is just a picture of the bone that has been demineralized or broken down. And again, the first stage is the synovitis or the inflammation. Then they get a fragmentation or avascular bone that gets reabsorbed. Eventually, reformation of the femoral head and neck and reconstitution with final appearance. These things occur best if the patient is kept in a cast, what you were talking about yet. Putting them into a hip spica cast and allowing the hip to stay in place, because when they finally reach that reformation of the femoral head and neck, they will have the best results.
So you
If
can
it's
take
in
a spice cast off.
Certain ones they do make very similar to, you might have seen the cast that children specialize for contractures. They have them that they pop on and off. Like almost like Velcro on the sides. Yes, with Velcro on the sides. I mean, it's a cast, and it's placed on, but it does come off and on. Very similar to those of you who might have seen patients with like because they make those kind for the contractures that children specialize too. So you might have seen it that way.
Okay, one of the stages is the newborn growth. Does that happen even if they didn't get treated?
Yes, even if they don't get treated, the problem is it takes longer to get through the stages. And the treatment for this is a lot of times things like the immunosuppressive drugs, because you want to suppress the immune response that's causing this. So they'll put them on high doses of prednisone, a lot of the other immunosuppressive drugs that they talk about, that they give to patients who've had like heart transplants and things, and IVIG is another one of those. So, they give a lot of these drugs to immunosuppress the patient, and then they will progress quicker through this. And the way they can tell is checking their sedimentation rate too. That sed rate, a lot of times, is very high in these patients when they have this. Those are some of the things for that. So again, the treatment is, the goal is to keep the femoral head in the acetabulum. Surgical intervention could be possible, casting, braces, or even putting in plates and screws, and education to the parents. Skin care, especially if they're in a cast, and possible activity changes.